the lung also moves out, isn't it? That's what happens, right? And although the chest wall moves out, lung doesn't move out as much, right? And this is the reason why you get a negative intrapleural pressure, intrapleural pressure negative. So it's minus 2.5 kPa, right? Minus 2.5 kilopascals. It's a very, 2.5 cmH2, cmH2. It's a very minute negative pressure, but that pressure is so important to. What does that pressure do? It is a very important thing. It prevents the lung collapse. That is the one that prevents the lung collapse. You have a negative pressure in the pleural cavity that prevents the lung collapse, right? So it's important to understand, right? So what happens in pneumothorax? Now, but the physiologically wise, pneumothorax, you can have, what are the types of pneumothoraxes? Okay, open pneumothorax or traumatic pneumothorax. That is following trauma. And then you have another form of pneumothorax called tension pneumothorax. It could be due to trauma, it could be well be due to a non-traumatic reason. Whatever it is, what happens is there is a flat valve mechanism that takes place in the pleural cavity that results in air only getting stuck in the pleural cavity. There won't be any leaking of air again coming back into the lung. That's a problem in tension pneumothorax. And you have the other form of pneumothorax, which is, what's the third form?
Crossed.
Sorry?
Crossed.
No, simple pneumothorax.
Crossed.
Simple pneumothorax is a catch-all term for all non-tension, non-traumatic pneumothoraxes, right? So what is simple pneumothorax is when you don't have non-trauma. Non-trauma means it's not open pneumothorax and no matter. It's a non-tension. Tension pneumothorax and no matter, and it's zero pneumothorax. It's a catch-all term called simple pneumothorax. Generally what happens is sometimes, most of the time, you get a phlegm, you get rupturing in, forming air, getting stuck in the pleural space, right? So that's usually what happens, right? And you all know why tension pneumothorax is bad. What happens in tension pneumothorax is you get tension built up in the pleural cavity that eventually results in tension on the large vessels in the thoracic cavity that reduces the venous entry or venous return, right? So that is what is known as tension on the blood vessels. That is why it is called tension on the blood vessels. So you have no reduced amount of blood coming back to the heart, so reduced venous return, and at the same time, because of tension within the pleural space, it will cause reduction of ventilation. So it's a combination of inadequate ventilation and poor venous return into the heart that eventually results in cardiopulmonary dissociation. It's called cardiopulmonary dissociation, and the patient dies as a result of it. If you don't, it's one of the immediate life-threatening injuries or conditions. In open pneumothorax, it's actually following trauma, and you have an open wound in the pleural cavity, into the pleural space. So when this wound diameter is more than 2/3 of the diameter of the trachea, preferably air enters through the pleural, air enters through this wound into the pleural space, other than air coming through the mouth into the lung. So that is the mechanism. That is why open pneumothorax is also a life-threatening, immediate life-threatening injury, right? Because of the diameter problem. So if the trachea's diameter is, let's say, 10 millimeters, and if this wound's diameter is more than 2/3 of that, air enters through this side rather than going through this because of reduced resistance. So those are the three principal types of pneumothorax, and I know you all know how to manage them. Tension pneumothorax, you put immediately you put two needles into the second intercostal space, the midclavicular line to get the air out, and then you can ICU breathe. And open pneumothorax, you put what is called Asherman, but it's the plaster, where you cover it up with three sides, allowing air to ingress and not to ingress. It's called ingressing and egressing of air. What's the term? That is the term that they use. When you put a plaster in, air will egress. That means air from the pleural cavity will go out of the body, but air won't ingress. Right? That is what the plaster does. It's called the asherman. Commercially available plaster is called asherman. Right. Okay. So those are the basics. Right. So this is pathophysiologically, that is how you divide pneumothorax into three. Then pneumothorax is again divided as another form. What is that? Etiologically. Spontaneous pneumothorax and traumatic pneumothorax. So spontaneous pneumothorax is again divided into primary and secondary. What is primary and secondary? Any idea of spontaneous pneumothorax? Okay, so classification of pneumothorax, the earlier one I told was the pathophysiological classification, right? Now I'm talking about etiological classification. These two are different, right? But more or less, what you need to understand is etiologically means causality. But what really happens inside pathophysiologically is what I have explained earlier. Right, okay, so what is primary spontaneous pneumothorax, or PSP? Idiopathy. Rupture of a blood or a bullous. Generally happens in tall males who smoke. Right? Tall males who smoke. That's the classic profiling of primary spontaneous pneumothorax. What happens in secondary spontaneous pneumothorax? SSP. You have an underlying lung disease. Primary spontaneous pneumothorax, the lung is perfectly fine. For some weird reason, a bullous, there has been a bullous, but the rest of the lung is all fine. But bullous gets ruptured and then you get pneumothorax. But here, the underlying lung is already diseased. There is some funny lung parenchymal disease is going on, and on top of that, you develop a pneumothorax. So that is bad because that pneumothorax is bad, right?
Lung function is
the underlying lung is already compromised. So if you further compromise the ventilation, that patient can die. Right? So that's important. Then you have, that is spontaneous, and you have traumatic. Traumatic is basically, you know that it's always open pneumothorax when you got it. But of course, tension pneumothorax can happen following blood trauma to the thorax. Right. So now, so what is an ICU? This is pretty much the basic understanding of pneumothorax. Okay. So how do you diagnose a pneumothorax? Clinically and radiologically. Good. So radiologically, chest X-ray is the thing that we usually do. Standard posterior or anterior chest X-ray is what that we are supposed to do. And what is the gold standard? Gold standard is C. Okay, gold standard to diagnose a pneumothorax is C. So we don't do it. We stick to clinicals and X-rays, but C is indicated in special situations where you can't really diagnose or your diagnosis is unsure and complicated cases, you will see. Right? So those are the investigations. And then of course you know what the management is basically putting an IC tube. So you need to understand in terms of pneumothorax, you don't put IC tubes to each and every pneumothorax. So it's basically a segue to IC tubes. IC tubes are pneumothorax and tube. I'm coming to IC tubes now. When you talk about pneumothoraxes, to which pneumothorax you would put an IC tube? First of all, tension pneumothorax is a must, right? Next final, tension pneumothorax is a must. Then open pneumothorax is a must, right? You do this, but you put an IC tube subsequently. You have to do this. But when it comes to simple pneumothorax, at which point are you going to put IC tubes? Would you put IC tubes to all, or will you selectively put IC tubes to simple pneumothorax? Huh? Yeah, it's a selective. Because of course there is a place for conservative medicine in those patients. So, what are the selective? What is the selective? In simple units. I can't hear. Progressive. Progression also okay. How do you know, okay, this patient, as an X-ray in front of you, as a patient with simple pneumothorax, you know that it's not tension, because how do you know it's not tension and simple? Again, clinically, this patient will not have clinical features of tension pneumothorax, which should be different to that of a simple pneumothorax, and those would be tracheal deviation. No, hyperresonance will be there in any pneumothorax. What are the things that will differentiate simple pneumothorax from? Tracheal deviation, number one. Number two? Reduced and will be there in both pneumothoraxes. Distended neck veins. Yeah, distended neck veins and elevated JV, they are basically the same. And hypotension. You will get hypotension. Tracheal deviation, hypertension. Those will not be there in simple pneumothorax. By definition, those should not be there. You will have those, then that becomes a tension pneumothorax. Okay, so you need to understand this very clearly. What is the difference between simple pneumothorax and tension pneumothorax before you know anything else? Clear? Right. So once you know that this is a simple pneumothorax, you know that this patient doesn't have tension, so this is a simple pneumothorax, and there's an X-ray writing system. So how do you decide on putting an ICU? Anyway. Yes. No, I gave you the X-ray. So that means you have to decide on something on the X-ray that tells you, okay, this patient needs an ICU. That is the first rule in pneumothorax, ICU fixation. It is not tension now. Yes? The size of the pneumothorax. Obviously, size of the pneumothorax. So what is the size of the pneumothorax? How do you know this? No, not half. Yes. Huh? So there's a specific number, right? Now, when you get the chest wall and you have the lung, you have this air column. If this air column is more than 2.5 centimeters at the second costal cartilage level, that is an absolute indication for a simple pneumothorax to be managed with an ICU. Understood? Chest wall, lung. So that's a lung. This is a chest wall with your ribs. And this is the parietal pleura. This is the visceral pleura. If this air column is more than 2.5 centimeters at the second second costal cartilage. This is your, how do you know it's your second costal cartilage? Angular Louis. Right? At this level, if it is more than 2.5 centimeters, on a standard, this statement has to be followed with on a standard PA X-ray. It has to be a standard PA X-ray, not a haphazardly taken, elevate, rotate X-rays, right? So it has to be a standard PA X-ray, and if you have that, that's an absolute indication. If it is not a standard X-ray, so when you say this, before I go to the next statement, when you say this, if you have a pneumothorax by this much, why we put an ICTUB is, if you have a pneumothorax of this much, it is already, that lung has reduced in its size more than 50%. That is why you put an ICTUB. It's a huge amount. Right? The volume has shrunken more than 50%. Then, if it's not a standard X-ray, substandard X-ray, then the pneumothorax has to be more than 33% your monthly of the lung volume. Lung volume එක වගේ තුනෙන් එකක් තියෙනවා නම් pneumothorax එක, that is an indication to proceed and put an ICU.
That is volume wise or length?
Volume wise, it's the appearance. What you see with your eyes. Lung එකේ මේකට වඩා lung එකේ එක බලනවා, you can compare with other side also. Right? So if it's more than 1/3, you have to put an ICU. Yeah. No, PA. Take PA. Right. You mean why it is not standard means? Yeah. And basically it cannot be stood up or things like that. Or rotated. So it's a judgment at that point. Patient's clinical presentation, how patient is listening, how badly listening the patient is, and the appearance of the pneumothorax. So that's how we decide on that. So simple pneumothoraxes which do not fall into this category, you don't put IC tubes unless, there's an unless. There are 3 other situations where you will again put an IC tube. What are those? Number 1, the patient has only 1 lung. Number 2, if patient has underlying lung disease. Okay. Number 3, if these simple pneumothoraxes are bilateral. Unchi, but they better. So those are the indications where you will put IC tubes to simple pneumothoraxes which do not qualify this criteria. So that's pneumothorax. Clear? Pneumothorax and IC tube insertion. Right. Now before I get on to the rest of the IC tubes, what is a chest drain? What is a chest tube? What is a chest tube? What is the definition of a chest tube? IC tube is one of the chest tubes, right? What is the other type of chest tube? You put a tube into the pleural space. So there are pleural tubes also. Sorry, you put a tube into the pericardial space. Pericardial tubes are there, especially following cardiothoracic surgery. So chest drains are a universal term that will be inserted into the thoracic cavity to remove excessive collections of blood, fluid or air. So that's the definition of a chest drain. So intercostal tube or an IC tube is one of the chest drains. Okay? So now you know what the type of pneumothoraxes are and how you manage pneumothorax and what are the indications of pneumothorax for IC tube insertion. Okay. Now the next question is, what are the indications for IC tube insertions? Now pneumothorax already we have covered that part. Okay. So what are the indications for IC tube insertion? How do you classify it? Yes? Prophylactically. Okay. So prophylactically means so following surgery. Okay. So that's the term. Post-operative. That's one indication to put IC tube. So post-operatively, prophylactically, following esophageectomies, we generally put bilateral IC tubes. Following each and every thoracic surgery, we put an IC tube for sure. Right? It's a must. Generally, we put 2 IC tubes actually. Following some intrathoracic surgery, we put 2 IC tubes. You don't need to know that. Right. Number 3. So that's not number 3. No, that's number 1. Post-op. That's the first category. Second category, post-trauma. Okay. Post-trauma. So post-trauma, why we put IC tubes. Then, what are the other situations other than these 2? Post-operative. Third category is that. So third category is known as non-operative, non-traumatic situations. Okay, so there are three categories of in situations where we put ICUs. Post-trauma, post-operative, and then the third category is non-traumatic, non-operative situations. Non-traumatic, non-operative situations, number one, we have already discussed, which is pneumothorax. Okay, pneumothorax. Non-traumatic pneumothorax, simple pneumothorax managed by VDI. Tension pneumothorax, which is not due to a trauma, managed by VDI, we have discussed. Are we clear? Number two. That's the second situation, which is non-traumatic, non-operative. Okay. Now, think of situations where I said you will be putting an ICU when you need to basically get rid of excessive collections of blood, fluid, or air. So, air. Now done. Air can have the liver. So, you can get the situations. Pneumothorax, yeah. So, pneumothorax does not need to be traumatic. You can have non-traumatic pneumothoraxes, right? Non-traumatic pneumothoraxes you can have. Okay. So, okay, we talk about non-traumatic. So, we are talking about ICUs. Don't just be very candid. We are talking about ICUs. So, two mistakes. So, hemothorax, we put ICUs, right? Why do you have to put an ICU for hemothorax? Now, pneumothorax are the only indications ICUs are. Now, hemothorax. Are you going to put IC tubes for each and everyone, or are you selectively going to put IC tubes for hemothorax? Huh? Selectively. Huh? You put hemothorax, all hemothoraxes you will put IC tubes. Except, there is an except. I'll come to that. I'll come to that except part. But I need you to tell me why you put an IC tube, all hemothoraxes. Except it's a footnote. I'll tell that. At your level, if you know that all hemothoraxes should be managed with an ICU, yes, that's a statement, yes. Except is a footnote. I'll come to that footnote. You tell me why we have to put an ICU to all hemothoraxes. Yes? Exactly. Blood is not irritant is not the term, because we use that term for peritoneal activities. Rural irritant, no. That's not the reason. Huh? Exactly. If you leave blood, it becomes hematoma. It forms a hematoma, and then it becomes fibrotic subsequently, because it gets organized and fibrosis process. And as a result of that, that particular part of the lung also gets fibrosed, and this reduces the ventilation. So that's number one. Second reason is why we put an ICU all the time. Second reason. Because this hematoma it will easily get infected. That's the second reason. So you don't want that to happen. So these are the two reasons why you want all the blood to come out. Are you there? Right. Now for the footnote, why we don't put an I said except there are few situations where we don't put hemotherapy. So those are, number one is ruptured aorta. Right. Patient can know if you suspect ruptured aorta, you never put ICUs for those patients, because you are going to examine the patient. You are going to examine the patient. The entire blood will come out if you are creating another pathway for the blood to come out. Now, because the aorta is ruptured, our body's mechanisms or whatever the mechanisms are now keeping it contained. If you put an ICU and makes that tamponade effect go away, that is the end of the bit, right? So you never ever put an ICU for a patient whom you are suspecting aortic rupture. Okay. Side question. Aortic rupture. How do you diagnose? What are the features in the X-ray to say suspected aortic rupture? Trauma case. How do you suspect aortic rupture? Yes. She says this, and I know that. Yeah, that's widening. What is that? Widening of the medial sternum. How much? That you know. How much? ඒක දැනන් ඉන්නවා. කොච්චර ප්‍රමාණයක් කියලා තමයි. දැන් මේක වයින් කියලා ICP දාන්න. ICP කොහොමද දාන්නේ? Okay, so how much of bite is there? 8 centimeters. There's a valley. There's a valley. Surgeons are very fond of these numbers, no, sometimes. 8 centimeters, more than 8 centimeter is wide in the previous diagram. Or if you can't measure, then 1/3 of your chest X-ray. Chest X-ray ke lung fields again more than 1/3 then that's considered as one feature in the setting of a trauma and suspected aortic rupture, right? That's number one. Number two, what are the other features in the X-ray? Anybody? Aortic knuckle like a. Do you see an aortic knuckle in a usual X-ray? That aortic knuckle won't be seen. It will be covered with a hematoma, so that area will be hazy. So that's the second feature. Number three. So remember this: if a patient who comes following trauma and patient is extremely hypotensive and pale, you don't see any other injuries outside. This happens most of the time. This happens in the accident series. You have no idea what is happening. A patient's blood pressure is crashing, and eventually you have to, when you check the air entry seems all right. Basically, nothing in the abdomen will stop, but patient is crashing. And you take a chest X-ray, and if you see this aortic knuckle hazy, you have to suspect aortic rupture, because some of the patients following aortic rupture will come to the hospital. Right? Those who survive the initial impact will come to the hospital. That is because why? Because the bleeding is now contained. That's why. Right. Okay. So haziness in the aortic knuckle region. Number three. Third feature in the chest X-ray. Pleural caps. There's a thing called pleural cap. Do a Google search, you will see what a pleural cap is. Pleural cap is a feature of aortic rupture. Pleural ke udahari ko caps de aapko sudhu baata blood ekathu වෙනවා. Pleural caps. Number 4. Trachea shifted to the which side? Huh?
Trauma.
How many sides you have? Right and left, no? Right side, because the aorta is on the left side. Okay. Trachea shifted to the right side. Number 4. Number 5, sorry. Number 5. Last feature. This is very exhaustive. Your carina, you have the trachea, you have the carina, like that, and then you have the right bronchus is like this, and the left bronchus is like that. You know that, no? Right bronchus. That is why you get food stuck in the right bronchus, because of the less obtuse angle. Now, the left bronchus has an angle like this, but if you have a hematoma due to a rupture of the aorta, this will be pushed down levels. So this obtuse angle is now converted to an acute angle. Acute angle can make acute angle. Okay? So obtuse angle of the left bronchus will be converted to an acute angle. So these are the features of aortic rupture. I just digress because right. Where were we now? Footnote. So footnote so yeah, so you don't put ICTs if you have an aortic rupture, and also if you have arteriovenous fistula formation. Arteriovenous fistula avilla hemothorax ela kattiyata you don't put, because you are going to examine the patient. And footnotes. Right. So at your level, remember hemothorax will need an ICU. Right. Okay. So pneumothorax, hemothorax. Number 3, non-traumatic, non-operative causes of ICU fixation. Number 3, chylothorax. Yes. Chylothorax is what? Huh? Chylothorax is not pus. That is pyothorax. Huh? Lymph, yeah, lymph. Okay, so chylothorax. So how do you differentiate? Good question. You said pyothorax because you confused them. It's like both are equal. Pyothorax katta sudu pada deyak keliyenne, chylothorax katta teliyenne sudu pada. So how do you know the difference? So first of all, why do you get chylothorax? Because the rupture of the thoracic duct. It could be a traumatic rupture or an iatrogenic rupture, whatever. So how do you know that it is not pyothorax and it is chylothorax? You do. First of all, it's the milk. It is milky color. Araka passaka make a milky color. There is a difference between the color. But if you can't really say the color, then you do some tests. So if you look at the content under the microscope, you will see that this has polymorphs and this will have lymphocytes. And if you do the chylomicron test on this chyle, it will be positive for chylomicrons. So that's how you know it's chyle. So chylothorax is an absolute indication for ICU insertion. There is no hanky-panky business there. Chylothorax, always you put an ICU. Okay. Number 4, pyothorax or empyema-thoracis. So what are the types of empyema-thoracis? You can have localized empyema-thoracis or generalized. Why do you get localized and why do you get generalized? What is the reason? Basic reason is our immunity. If you have a fair bit of immunity, the things will get localized. If you don't have immunity, it will be generalized. ICTUP is only indicated if it is a generalized empyema or a generalized pyothorax. For localized ones, you are not supposed to put ICTUPs here because you can't do it. You have to do it by ultrasound, guided aspirations. Yeah. So indication for ICTUP insertion for pyothorax or empyema-thoracis is generalized empyema-thoracis. Clear? So what is the last one? Oh yeah, man. Okay. Yeah. Pleural effusion. That's the 5th indication for an ICU. So, in which patient are you in pleural effusion? Now, let's say one fine day you become a surgical registrar and you get a referral from a medical ward. Say this patient has a pleural effusion. Can you please put an ICU? What is the indication of an ICU for pleural effusion? Okay, if the patient is in respiratory embarrassment because of the pleural effusion is very large, that is a relative indication for ICU insertion, right? Pleural effusions actually should not be managed with ICUs. They should be managed by tackling the underlying disease causes. You have to tackle the underlying disease causes, right? So the indication to put an ICU is either the patient is at the moment having medication for the underlying disease causes, and we want to get rid of the pleural effusion and relieve the patient of respiratory embarrassment. Or number 2 is sometimes these pleural effusions are never going to resolve on their own. The only way that you can resolve a pleural effusion is by making sure. Why do you get fluid collected? Because there is space to get fluid collected. So the only way to stop this from happening is by getting rid of the space to get fluid collected. So what is that? What is that? So you get rid of the pleural space. How do you get rid of the pleural space? No. The thing called pleurodesis. Have you heard of the term pleurodesis? The parietal pleura and the visceral pleura is adhered together to get rid of the pleural space. Never heard of this term? Pleurodesis. Pleurodesis क्या term में कहा है? මේ ස්පේස් මේකයි එකට ගෙනල්ලා අල්ලවනවා. there are few ways the surgeon can do this. I thought you have pleural effusion medicine so the only way that you can do it is by making sure that there is something ready. There are few ways we can do it. One thing is we can get rid of sorry, not this one. This parietal pleura. Parietal pleura can strip off the surgery. Let's check out the camera. Strip off the. So that's off the parietal pleura. You have to make a powder down my space. Talc pleura is talc pleura. So that's the second way. Third way is we can create abrasions on the lung surface. Some cheesy thing to do, but that's another way. Right? So if you have plans for pleural disease only, or the underlying disease surface is controlled or is being controlled, that is the only indication to put an ICD for a pleural effusion. Understood? That's the bottom line. Either pleural disease has to be planned or underlying disease process has to be controlled. Otherwise, pleural effusions are not going to get corrected. What are the reasons for pleural effusions? What are the types of pleural effusions? Medicine perspective. Sample perspective, exudates and transudates. Exudates and infection is malignancies is transudates and because of heart failure, you have your liver failure, heart failure, kidney failure, cases transudate. So as you can understand, there is some underlying disease process always. That is the reason why this happens. So make sure that it is not there. Right? Okay, so those are the indications for ICD insertion. Is it clear? Right. Okay. The manga and home the ICD ka daan nikla. Because it's important for you all. Ek register lage question. What is important for you all is the subsequent management of ICD. Right? Okay. Okay, so let's presume that the ICD has been put for this patient. Let's presume that the patient is having an ICU. Now patient is in the theatre. Your registrar Abdullah has put an ICU. Patient is going to come back to the ward. So number one is, let's say you are the house officer in the theatre. Then after you need to take a house officer, the theatre can manage it. Downside in this unit, but when you are a house officer, you have to be in the theatre, right? So now the registrar has always whoever has put the ICU. Now the patient belongs to you after that, right? So what are the things you are going to check at that point? And once the patient comes back to the ward, first of all, at that point, you make sure the patient is now feeling better. So the patient that had a reason to be put in ICU. Now, patient should be feeling better. The respiratory rate should go down, right? And pulse rate should not go up. Right? Clinically, patient should be getting better. That's number one. You have to auscultate and see how the lung bases and air entries. Right? That's the second thing you have to do. The moment you put an ICU, patient starts coughing. Right? What is the reason? I think that's all. Registrar ICU पे दावा patient कहीं ना पढ़ा. वो कहते हैं दाला निकला ही कहीं दाला या तक के दाला ये नोट मेरे patient है कहीं ना. What does that tell? Yes. Yes. Chest is expanding. That's what it means. Your parietal pleura and visceral pleura, if they come and touch each other, you get a cough. It's a reflex, right? So when you put an ICU and ICU can dabu among, especially for pneumothorax, air will quickly come out. Takdala air apu among parietal pleura ke visceral pleura ke vadina. Then you get a cough. So it's a good sign. So if the patient gets cough, you have to tell the patient. Whatever. is coming out. Right. And then you have to make sure that the IC tube is properly anchored and all that. Go and there register and you have what is called the underwater seal. Take a connector and underwater seal. Now patient is going to be sent back to the ward. So when the patient is going to be sent back to the ward, number one, make sure that IC tube is never ever clamped. Right? IC tube clamped. Number one, you have to keep the bottle below the level of the patient's heart. That's number one. Number two, don't clamp. Right? What is the problem of clamping? What is the problem of clamping? Huh? I can't hear what you're saying. Yes. You are going to invariably create a tension pneumothorax. Right? Now you have basically closed up the only way of the air to come out. If the reason for pneumothorax is still persistently there. Let's say a ruptured pula is there, now you have put an IC tube in. And there is no way of the air to come out. So you are going to create an unnecessary, you are going to, not that it's going to be a tension pneumothorax, but it's going to be, the reason that you put the tube is not going to be the thing now. Right? You put the tube to get rid of the air, now you are putting a clamp. So on the way, patient can get bad. Right? Patient can deteriorate. That is the reason why you should never put a clamp. Then on the way, you have to take an X-ray. Right? And you get the patient to the ward. So once the patient comes to the ward, what will you do? You are the house officer in the ward. First of all, you will put this patient to the acute site first aid. Right? And if possible, connect the patient to a multi-monitor. Then you will, the house officer, the ward should immediately attend and reassess this patient. Remember that, right? ICU patient there are few patients I told you that they are supposed to see. Then there are few patients. Now, post-operative patients. Whenever the patient comes to the ward, you have to see him. Because you are the baseline. House office is the baseline for the patient's clinical status. Ward operate ward document baseline if the patient deteriorates something. So that's vital that you all see all the post-operative patients when they come. So there's not much no. So, immediately you come and assess the pulse rate, blood pressure, respiratory rate, and the patient's abdominal tenderness and the pallor, and those things you document in the ticket. That's very important. So, similarly, this patient also you have to immediately attend. You have to talk to the patient and see how the patient's comfort levels are now. Examine the lungs and respiratory rate, blood pressure, pulse rate, and all. Document. Check the IC tube and the bottle, whether it is screening, functioning, and check the chest X-ray that was taken on the patient. So those are the 4 things that you have to do once the patient comes to the ward. And then what will you do? Now you have put the patient to the acute side, connect the patient to a multi-monitor, assess the patient in that order that I told you. Then what? Prescribe patients analgesics. Prescribe patient incentive spirometry. Prescribe patient chest physiotherapy. And prescribe steam inhalation. So those are the things you have to do. Remember, these things you have to document on the ticket. Management plan, incentive spirometry, nurse spirometer and patient patient. Why do you do all these things?
Like,
Exactly. Lung expansion. You want the lung expansion to occur. That is what you want. So by giving analgesics, you get the patient to breathe in and out properly. By giving chest physiotherapy, steam inhalation and incentive expansion, you try to achieve lung expansion. Right? That's why. Right. Initial management. Then you are going to manage the IC tube and the bottom. Right? So what are you going to do in terms of those? Number one, you have to make sure the tube, the one that comes from the patient's body to the underwater seal. දැකලා තියෙන වාට් එක ගොඩක් වෙලාවට ඉස්සර හැමතිස්සෙම කියනවා. ඒක ඔය අර excessive amount එක ඔය එහෙම එල්ලීලා වැටලා තියෙනවා ඇටේ පාර. That should not happen. The excessive amount of the tube should be in a transverse plane lying on the bed. And from the point of the edge of the bed to the IC tube, there should be a direct line going like this. That's important. Because you don't want unnecessary pressures to be created in this system. The rest has to be in a transverse plane. If you keep it in a transverse plane, there won't be a pressure. Pressure occurs along the vertical plane. Number two, you have to clip the IC tube. IC tube and the bed linen clip color so that it won't be going here and there. And it won't cause pain to the patient when patient turns around. Otherwise, may clip කරේ නැත්නම් patient හරියට හැදෙනකොට ICU bottle එකක් දෙල්ලෙන ගන්නවා. Right? Underwater, that will cause immense pain to the patient. That's not good. That's another important thing. Then number three is the bottle. The bottle should be kept inside a flask. Cardboard box එකක් ඇතුලේ තමයි ideally තියලා තියෙනවා. If you go to cardiothoracic units, you will see that every patient's ICU is kept in it. Almost all patients will have an ICU in those wards following post-operative. So, or you will have cardboard boxes. Why do you need a cardboard? Because it will prevent this falling over or tipping over or whatever. And then you can do the other important thing is then I'm talking about how to take care of an ICU. So you take a bottle like it, and then over some time what happens? Things from the lung will come out through this tube and it will form a coagulum. Coagulum, then it will stop functioning. So to prevent that, you have to do occasionally you have to do milking the tube. Tube like a milk done on accumulate. These are supposed to be done by nurses. They do that. You have to make sure that they do that. You can't say anything. At least you should know that these things should be done, and if they are not doing, you have to tell them to do this. In the water, nurses should do these things. And there are a few things that we can do to help the patient expand the lungs in terms of the ICP also. You give the patient analgesics, chest physiotherapy, incentive expansion, steam inhalation, all that is to expand the lungs now. So like that, you can do something to the tube also, or to the IC tube system to help the lung expansion. Any idea? Now what happens in the ICU? I will draw the ICU. This is last time when I do this, people got confused. Again, I'll make sure you will get the system. Right. So this is the ICU, right? This is the underwater seal. And make water. So one goes to the water, right? So this is the one that comes from the patient. Right? Make a patient, this is just the outside. Okay, patient, so, api to air in here, If air comes here, there will be bubbling. Sorry, bubbles over again. Right, okay. So there will be bubbling, right? And then we have water here, isn't it? And it's all water. Okay, mechanism is basic mechanism. Meaning air, meaning bubble, bubble when air take method, air take method in here. That is the mechanism. Now presume you put an IC tube for total effusion or hemodialysis or whatever. Then what happens? Some other patients like air in the full lung. Maybe traumatic patients will have some rupture of the lung surfacing and rupture like air leak in the full lung. But most of the time they have blood coming in. What happens? Blood will now come in and it will get accumulated here. Because I'm going to make it in this level goes up. When this level goes up, right, this creates an unnecessary pressure on the lung, this additional amount. We don't want that to happen. When this this extra column will create unnecessary strain on the lungs. That will prevent the lungs to expand. Unnecessary pressure, lungs can't expand. Because this is all a closed system, you need to understand that. This is all a closed system. So, if that, to prevent that, what can we do? Yes? Have a butter. How do you drain the excess? Yeah, that's the answer. You have to drain the excess. But how do you do? I don't know why they don't do it like that. They don't do it like that. Instead, they do something similar, which is not the same. Similar but not the same. Right, okay, so instead they get this tube into another bottle, and this is now the one that is coming from the patient. This is not the patient now, this is the patient. How is it? If fluid is now coming, fluid is going to get filled here. Fluid is now going to get filled here. Fluid is going to get filled here. This is fluid. Air is going to come through this one and bubble this like before, and that air will go through this. Now the lung is only exposed to a water column of this. Understood? So this is called a trap chamber. So this is commercially available. I don't know whether you've seen this. It's commercially available. When they come sets the main commercially. So this is one thing that you can do. Adding a trap chamber. Trapping the fluid. Have no confusion there? I make confusion. So this is the only water column that the lung will be exposed to. Right. This is to help the lung expansion. There's another thing that you can do to help the lung expansion. I think people got confused when I said that. But I will say it again. Okay, so anything else you can do to help this, lung expansion other than this mechanism? Yes, that's the answer. Suck out. Suction. Right, you apply some suction to this end so that more air will, whatever that is collected, air or fluid or whatever, there's negative pressure, suction down, lung level later. But that has to be a very minimum amount of suction. You should not put a lot of suction. Suction apparatus control suction. So you put suction to this. suction apparatus connected. Then make a suction apparatus connect what the most important thing you have to make sure is this suction apparatus works. If this doesn't work, what will create here? This is going to create a closed system. So suction apparatus at Dhanavana, it is imperative that this works. Suction apparatus works. Right. සමහර වෙලාවල දැන් suction apparatus අපේ වාට් වේ තියෙන suction apparatus අපිත් දැදිලා යනවා වගේ suction apparatus තියෙන්නේ වාට් වේ. අයිකල් බලන්න මාරස. නේද? ඒවා මේවට අයි කරන්න හොඳ නැහැ. Right? You have to have a very small suction. So we don't have those suction apparatus unfortunately. What they say is you have to apply about 20 kilopascals over පොඩි ප්‍රමාණයක් තමයි දාන්න කියන්නේ. We have 100 kilopascal suction apparatus. We can't put 20. So, to mitigate that problem, there I will be adding another bottle, but don't get confused if I add it. Is it okay if I add that and show you? Yes. Well, previous group got right now I confused with that. I can add it. Right? I'll add it and show you. Can remember how you run it. Now, make simple suction apparatus and make no, the reason I'm telling you is you have these things working for you have all these units. So it's important to know these. Very important. But then you have the third bottle. Right? So the third bottle has three things like this. Let's say now this one is the one that is connected to this one. This one is the one that is connected to your Avashiti suction apparatus, which produces a lot of suction. Now, mixture to get suction time make a kelima method high karoti. Make suction apparatus a kelima method make it high karoti. So you don't want that to happen. That is why this apparatus is there, right? So what this does is, now what they say is to have minus 20 cm H2O of suction pressure, minus 20 cm H2O of suction pressure for the lung to get properly expanded. Lung expand කරන්න අපි දෙන pressure එක ඒක, negative pressure එක ඒක. ඒක අපි දෙන්නේ කොහොමද? මෙතන water තියෙන්නේ. You can see that this tube is exposed to the environment. Make a suction apparatus එකට දාලා ඉවර වෙලා මේක අපි පොඩ පොඩ වැඩි කරගෙන යනකොට දැන් 100 kilopascal කියවට මේක 100 කපාට 100 තම වලින් මේ නැහැනේ. ඕකේ මේකක් තියෙනවානේ. ඒක අපි වැඩි කරගෙන එනවා. වැඩි කරගෙන එනකොට at one point there will be some bubbling because air gets sucked through this. Outside air මේක ඇස්සෙන් එනවා මෙතන. ඇවිල්ලා මේකේ minimum bubbling එකක් එනවා. and මේ minimum bubbling එක මේ water column එක 20 cm උස නම් මෙන්න මේ 20 cm උස water column එකේ minimum bubbling එනවා කියන්නේ we have applied negative 20 cm H2O pressure to this chamber. And that is going to get to the lung. Understood? ඒක තමයි concept එක. දන්නේ තේරුණාද? මේ වැඩි ආනන්නේ තේරුණාද නැද්ද? Okay. Right. So this part is called a trap chamber. This one also has a name. A negative pressure. Negative pressure. Trap chamber, negative pressure chamber, underwater sea. Those are the three terms. Anyway, okay. Here, I hope you understood, right? So now, that's what you are supposed to do as a house officer. Not this. But the ones that I told before are the ones you are supposed to do as a house officer when the patient comes back to the ward. Clear? Then IC tube දාන indications හරි දැම්මා. දැන් මම ඊපස්සේ patient එක බලාගත්තා. tube එක බලාගත්තා. then tube එක ගලවන්න යන්නේ. හරි? හරි. So when you are going to remove the IC tube, there are certain. So when will you remove an IC tube? When the purpose is no longer there, and the purpose has been served, or the purpose has been served. That is applied to any drain, universal statement. So likewise, it's the same for IC tubes. When the purpose has been served, you are going to take the tube out. So how are you going to now talk about this? Well, it depends on the patient. Patient means it depends on the pathology. How are you going to remove an IC tube put for? Pneumothorax will be different to that of a hemothorax, and it will be different to that of a pylothorax, and it will be different to that of a pyothorax, and definitely it will be different to that of a pleural. Right? So there are different ways of how we decide on when to remove an IC tube. Pneumothorax, which is commonest thing of pneumothorax. When will we remove? Number one, patient has to be clinically improved. Before we remove the IC tubes, there is another part I forgot to tell you. Troubleshooting. As a house officer, how do you troubleshoot problems in the ICU? That's very important. So, what are the problems you can get in an ICU? Now the patient is in the ward, you let me put, you come to the next ward round, the next morning you come to the ward and you see few problems in this. Number one problem, common problem is persistent bubbling. Dal, tamat bubbling. Because you are supposed to get rid of the bubbling after some time. So what if there is persistent bubbling? What are the reasons and how do you tackle this as a house officer, as a doctor? So there can be several reasons for this, right? So we troubleshoot it in such a way that we get rid of problems. So number one is you have to think of a possibility of problem with the tubing system. Exclude bubbling, persistent bubbling. So how do you exclude that?
Check.
Yeah, so how do you exclude that? Exactly. You put a clamp at close to the patient chest wall. Kalla dala bano tamat bubble වෙනවා. Kalla අර suction apparatus එකට ගහනවා. නිකන් දීපට bubble වෙන්නේ නැහැ. ගොඩක් වෙලාවට. You put a suction apparatus එකට high කරලා දෙනවා. එතකොට bubble වෙනවා නම් problem එක තියෙන්නේ patient ගේ ඇඟ ඇතුලේ නෙමෙයි එතනින් ඔබට තියෙන තැනින් කොහේ හරි problem එකක් තියෙනවා. Some kind of leak. So it was then you get this clamp, where you put it further. And at one point, the bubbling will stop if there is a problem in the tubing system. So then you sort that out. So if there's something wrong with the external part of the tube, then you will put a new tube. Or if there's something wrong with the IC tube, then you have to get a senior to put a new IC tube, whatever. Right? So that's number one. Second possibility is that Coca-Cola bubble වෙන්නේ නැහැ. Bubble වෙන්නේ clamp හරියන් පස්සේ bubble වෙනවා. ඒ කියන්නේ there is something going on with the patient. So a second possibility could be fenestration it has come out. And now when the patient breathes in, air is getting through this and going through that. Area top fenestration making air no pathway. So that's why it's bubbling. Persistent bubbling. So fenestration. What will you do for that? Yes? Exactly. You remove the IC tube and put it in one. You never ever push the IC tube back in. That's the rule. Right? If the fenestration has come out, you don't put it back. The third possibility is maybe මෙතන දාලා තියෙන wound එක අපි කපපු wound එක තියෙන්නේ tube එක maybe bigger than the tube. අපි සූචක කරලා හරියට සූචක දාන්න. There's a gap. That's why air is getting through this part. කොහමද air ඇතුළට ගිහලා we have created an open pneumothorax situation and again after ICU bed දාන්න. So that may be another reason. Again, you can mitigate that problem by adding another suture there. So put a new suture here. Close down. Or එකක්වත් නෙමෙයි නම් reason. Then we have to consider the possibility of a continuous pneumothorax formation due to a persistent leak from the lung. Right? එතකොට lung එක ඒ කියන්නේ ඊටම lung එකේ surface එකෙන් persistent leak එකක් තියෙනවා. So then what will you do? හරිද? So you connect the IC tube to a suction apparatus. If you have not done it already, you connect it to a suction apparatus, because why most of the time this pneumothorax will settle on its own if the lung expands properly. So you have the lung expanded out or ill bahena. For you to close the holes, you have to get the lungs to expand. For that, you have to help the system. So you put a suction apparatus. If you have not put a suction apparatus on, if you have put a suction apparatus, you increase the suction by 5 kilopascals, right? And you give chest physiotherapy to the patient, steam inhalation, Dila energy 6 Dila patient, so that the lungs expand. You watch for another 48 hours. If the patient's bubbling does not settle by 48 hours, then you will call the help from the cardiothoracic guys. Cardiothoracic guys, they will do something about it. What they do basically is they will achieve pleural disease again. They will do it. Right. So that's excessive bubbling. That's one troubleshooting. Number 2 is you come to the ward round the next day, or maybe second day of ICU, and you see that the damn thing is not swinging. It's not swinging. It was swinging yesterday, it was fine swinging yesterday, but it's not swinging now. What? What is the possibility? What are the possibilities? Number 1 is that the problem is now solved. Lung is now fully expanded. When the lung is fully expanded, whether the visceral pleura comes and touches the parietal pleura, there is no way that you can have a swing. You can understand that for you to have a swing, there has to be a gap, right? Lung එක මෙහෙම වෙනකොට ඒ lung එකේ මේ gap එක තියෙන නිසා තමයි you get the swing. When the lung comes and touches this, you can't have a swing. So that's number 1. Second possibility is you may be blocked. That's the second possibility. So you assess the patient. If the patient is clinically well, lungs have expanded, you do a chest x-ray and it's fine, lungs have expanded, the possibility is that now it's good, it's all right. But patient is bad, still dyspneic, tachycardic, tachypneic, right? Lungs are not expanded clinically. X-ray doesn't show expansion of the lungs. Then you have to consider the possibility of a block, right? So then what you will do is initially you try to milk the tube. This is what happens when you don't milk the tube. So you milk the tube. Then if that is not going to work, then you will have to put a new tube in. Right? You never ever do irrigation over current ICU. Right. Then the third problem. You come to the ward round and you see that the patient is having crepitus over this area. Following ICU session. What will you do? What is the reason? Surgical emphysema. Why? Can you have it? Yes. Reason? Huh? Yeah, that's a pathology, no? I'm asking why this happens. Why does it happen in an ICU? One thing is is when a fenestration comes up to the subcutaneous plane. The fenestration, the last fenestration of the IC tube in an X-ray, when you take the X-ray, this is what you have to look for once the X-ray has been the last fenestration and the chest wall. Like after 2 centimeter gap, minimum 2 centimeter gap. It should not be more actually. That means the tube is too big. It should not be less so. So then that means the fenestration is now about to come to the subcutaneous plane. So there should be a 2 centimeter gap between the rib cage and the IC tube's last fenestration. So if this fenestration comes to the subcutaneous plane, that is one of the reasons for surgical emphysema. The other possibility is so if that is the case, what? If that is the case, you remove the IC tube and put a new one because you never push the IC tube back. The other possibility is දැන් අපි IC tube එක දාන්න කියලා skin එක කපනවා. Skin එක කපලා ඊට පස්සේ plura එකේ hole එකක් හදනවානේ muscle separate කරගෙන plura එකට දාවට කියලා plura එක කඩනවා. කඩලා තමයි අපි enter වෙන්නේ. ඔය plura එක කඩනකොට සමහර වෙලාවට අපි අතින් we might create a bigger hole than the IC tube itself. Right? Hole in the pleura is now big. IC tube is like this, and the skin, an enthusiastic will describe, is very nicely tightly closed. Skin is now very nicely tightly closed around the tube. There's a hole in the large hole in the pleural cavity, pleural space. Sorry, large hole in the pleura. Tube is like this. What happens? Air gets pneumothorax එකේ තියෙන air ටික මේ pleura එකේ අතන එළියට එනවා. ඇවිල්ලා subcutaneous plane වලට යනවා. That's the second possibility. A larger hole than the tube itself in the pleura. So in that case, what we do is we will get a lot more than that. And register the suture ke dalo. There's a air that is ekadala dine air will nicely come out. Right? Clear? So give it about 24 to 48 hours, things will settle. So surgical emphysema is not a major issue. Then number 4, fourth problem, or the last problem. You come to the ward round the next day and you see that it is excessively swinging. Why is that? Right, the swinging fine, now it's excessively swinging. Swinging. Now the thing is, when the patient's condition is getting better, as I told you, swing should go away. You should have significant swing, or swinging like a minimum swinging at what is the minimum swing you have? It has to be less than 2.5 centimeters. Right? ඒක තමයි අපේ lung එක ඇතුලේ හැදෙන normal පරුසයේගේ negative intrapleural pressure එක. මේ negative intrapleural pressure එකට ගන්න පුළුවන් 2.5 centimeter වගේ පොඩි මොනවා. It's like about this much. It's like not a good swing. When you check on swing, nothing much. But now you go into excessive swing like this. Why is that?
It's been late already.
Excessive swing. That's why I started off with the physiology. It's because the gap between the parietal pleura and the visceral pleura is too much. That is why it's excessively swinging. It's not expanding, if at all. Collapsal aorta expanded in an it's not expanding. The reason why this happens most of the time is there is some fibrous layer of lung එකක් හැදෙනවා. That is why this happens. Right? So to mitigate this problem, what can you do? Again, you help the patient to expand the lung. So if you have not connected to the suction apparatus, you connect it. If you have connected it already, you increase by 5 kilopascals. Chest physiotherapy, steam inhalation, insert spinal good analgesics. You give all this and watch for another 48 hours. And at the end of 48 hours, still it's excessively swinging. Now you again call it arterial guys. Now what they will do is, they will come and remove this. They will remove this fibrous plaque. Right? Remove this fibrous plaque and get the parietal pleura and the visceral pleura to adhere together. That's also another form of fluorolysis, but before fluorolysis they will use what is called this removal of the hydrogen. That term is called decortication. So decorticate and fluorolysis, that's what they do for that. Decorticate and fluorolysis. You don't need to know all these intricate details, but remember that we will be calling thoracic guys. That is the point where you have to call for other terms. So 48 hours is the time that you give for these things to settle. Okay, so that's your troubleshooting of the ICU. Now we are going to remove the ICU. I told when you remove. So pneumothorax, when will you remove? Patient should be good, clinically better. That's number one. That means by clinically better, you all know what it means. Respiratory rate should be normal, lungs should be expanded, there should be no tachycardia, patient should be of no discomfort and all that, right? That's number one. Number two, chest X-ray should, before that, there should be no swinging, there should be no bubbling, and the ICU should not be connected to a suction apparatus. Suction apparatus at a connect ICU, there shouldn't be any swinging or bubbling. That's how we know that things are now coming back to normal. And then you do a chest X-ray and see that it's expanded and all that. That's fine. Then what we will do next is you will clamp the ICU. Clamp the ICU for 6 hours and see whether the patient develops any discomfort, difficulty in breathing and things like that. If the patient doesn't develop anything, then you remove the ICU. Okay, so that's how we decide on removing an ICU for a pneumothorax. The key here is, if you put an ICU for a pneumothorax, you have to keep it at least 48 hours before you attempt to do this. 48 hours, because it is presumed that the process of closure of these blebs and things will take 48 hours with the lung expansion. If you remove before that, then it might recur. Number two, hemothorax. When will you remove an ICU put for a hemothorax? Anybody? If you put a hemothorax, ICU for a hemothorax, minimum of 24 hours should be kept in the body. ICU has to be kept for 24 hours. After that, if there is no bleeding for 4 consecutive hours, there is no drainage, you can remove the ICU. Right? Okay. So it has to be at least minimum 4 hours of consecutive 4 hours. There should be no blood coming off. That is when you remove. Number 3, you put an ICU for empyemothoracis. Then will you remove? Again, clinical parameters. Patient should be getting better. Fever should go down. Leukocyte counts, CRP counts, inflammatory markers all should go down. Tachycardia should settle. Right? All of the patient should be improving for you to remove. And the second thing is the drain. The drain should be minimal. So it has to be less than 1 milliliter per kg. Less than 1 milliliter per kg per day. Drain වෙනවා. I can 50 kilogram මිනිස්සෙකි less than 50 තමයි drain වෙන්නේ දවසකට. එහෙම ඒ වගේ අඩු වෙන යනවා නම් then you can remove the that's pylothorax. Chylothorax. I said chylothorax is an absolute indication to put an ICU. So likewise, when you remove the ICU has to be kept at least for 48 hours without any drain. There has to be zero drain for 48 hours if you are going to remove an ICU for chylothorax. That's a very special circumstance. That's the indication to remove ICU for chylothorax. 48 hours, zero drainage. As you can see, all 4 conditions so far discussed have different end marks, or what you call end points for removal of ICUs. Last one is tube effusion. You will only remove an ICU tube that was put for a pleural effusion only if pleurodesis is planned. Pleurodesis planned kala tiyena nam vitarai or underlying disease process is now controlled nam vitarai IC tube remove. Otherwise to IC tube should be kept if you put it because it's going to drain every day. So those are the indications to endpoints to remove IC tubes. Okay. The last topic is how to remove an IC tube, because HO is the one who will be answering the ward to remove the IC tube. How to remove an IC tube? Make sure that the indication to remove the IC tube is now met. That's number one. Number two, talk to the patient and explain that you are going to remove the IC tube. Give preemptive analgesia. You have to give preemptive analgesia to the patient. Preemptive. Preemptive can painkillers. Pain painkillers that's post-operative pain management. Preemptive analgesia is before you get the pain, you give painkillers. It has proven beneficial. So you give a shot of, let's say, pethidine or maybe put a diclofenac up. That's the best thing. Put a diclofenac up, and then you start doing this. So what is the thing that you will tell the patient? So you remove the IC tube? Full expiration. Full inspiration. Deep inspiration. I told you one thing. So why do you do it in the deep media? So why do you do it in the deep inspiration? You were there. Liar. You were there. Okay. Yeah, then a deep inspiration. During the procedure. That's the answer. During the procedure, yeah, but again.
Patient might lose control of keeping the inspiration and start expiring.
That's right.
Then the lungs will collapse. When the patient is expiring, lungs will collapse. So if we hold the breath at expiration, patient will start inspiring and lung will expire.
Lung is at its maximum.
You're in a hurry. So, yeah. We use the wachana wala podi awala tiyene nata your concept is correct.
Lung is at
You
its.
sharing the thing. No, what can No, what you said was right. That is the reason. So idea is for you to have fully expanded lungs, right? Idea is for you to have fully expanded lungs and minimum pleural space. Actually, not fully expanded lungs, minimum pleural space. That's the end point. You need to have a minimum pleural space. You can have minimum pleural space at two different points in your respiratory cycle. First point is in deep expiration or full inspiration. You take a deep breath in, your chest wall moves out, lung moves out, both move out, and at the upper end of the inspiration, the pleural space is minimum. Then the second one, deep expiration or full expiration. Your chest wall is now collapsed, your lung is collapsed, but chest wall is collapsed onto the lung, and therefore there won't be any space. So these are the two endpoints. So you can choose either actually. You can tell the patient, lung in the puspa itakalla hari pus iyalata adala hari kiyala kiyanna puluwan theoretically. But the unfortunate thing is, when you pull it out, it causes pain. When you pull the tube out, it causes pain. And invariably, patient goes into the next part of the respiratory cycle, whatever that the patient was in. If the patient was in full expiration, chest wall is collapsed, lung is also collapsed, right? And when you pull it out, patient goes into the next part of the respiration, which is inspiration. Inspiration means initially the chest wall moves faster than the lung moves. So that creates a negative pressure inside the pleural space, and it creates the cause air to come in from the outside when you pull the tube out. So it will create a pneumothorax. But if you do that at deep inspiration or end inspiration, the next part of the respiratory cycle will be expiration. Expirate වෙනකොට chest wall එක තමයි මුලින් expirate වෙන්න මේ collapse වෙන්න පටන් ගන්නවා. lung එකට කලින් chest wall එක collapse වෙගෙන තමයි යන්නේ. ඒකත් එක්ක තමයි lung එක collapse වෙන්නේ. So always the pleural space will be negative minimum throughout. Inspirate වෙනකොට මුලින් chest wall එක ඇදිලා බලන්න lung එක ඊට පස්සේ ඇදීගෙන එනවා. So there is always a gap between that. Expiration එකේදී collapse වෙනකොට chest wall එක මුලින් collapse වෙනවා, lung එක collapse වෙන පස්සේ. Lung always follows the chest wall. Lung doesn't start the process. It's a chest wall that starts the process. Do you understand? So this is why you do it in the deep inspiration. Deep inspiration, deep patient and expiration. So you ask the patient to take a breath, hold it in maximum inspiration, right? And then you remove. So what is the position? 45-degree angle. So it's called the semi-Fowler's position. Then you tell the ward nurses that you are going to remove the ICU. Get bedding, gauze towels, gauze towel or swab pack එකක් හදාගන්න. මම නම් පුරුදු වෙලා ඉන්නේ ඒ දවස්වල ඉඳන් මම පුරුදු වෙච්ච මම චෝකාරින පුරුදු වෙච්ච එක. වැක්සින් නෙට්ස් තියෙනවානේ. වැක්සින් නෙට් එකයි gauze towel gauze swab එකයි වැක්සින් නෙට් එකයි gauze swab එකයි වැක්සින් නෙට් එකයි gauze swab එකයි. ඊළඟ මම පැක් එකක් හදාගන්නවා. 3 gauze swabs and 3 vaseline nets. This vaseline net is the one that will touch the patient's skin. This gauze swab will be the outside one, right? Will be touching the plaster. හරිද? මේ විදිහට පැක් එකක් හදාගන්න කියනවා nurse ට. බෙඩින් ප්ලාස්ටික් කරගන්න තියෙනවා. සිසර් එකක් ප්ලාස්ටික් කරගන්න තියෙනවා. සිසර් එකක් හරි blade එකක් හරි because you have to cut the suture. Once you are ready with all this only, you are going to now do it. So give the preemptive analgesia, tell the patient what to do, get the patient position properly, everything ready, and then you hold this one. Now sometimes remember we put what is called a retention suture එකක් දානවා සමහරවිට IC tube එක දානකොට ගැට ගන්න තියෙන suture එකක් දානකොට we put another suture and keep it there. That suture can be used to close the skin incision. So if that suture is there, you tell the assistant nurse to put a knot in it, tight කරන්න නැතුව knot එකක් දාලා තියාගෙන ඉන්න කියලා කියනවා. හරි? If it is not there, then you can't help. So you are the doctor now. So you are going to hold the IC tube in the right hand and this goes back in the left hand. Right? You ask the patient to take a deep breath. With a swift movement, you pull it out. Plastic color, biotic color, right? With a swift movement, you pull it out and immediately you put the back on the wound. And if the nurse has kept a knot and kept it like that, now you ask that nurse to tighten the knot. Practically, the tight benign, and then you put a plaster. So that's what you do. You have to know this because if there is a pneumothorax formed after removal of the ICU, that is totally on you because it happens. Right? But then you have to connect the patient to 100% oxygen and keep the patient in water for some time. Not discharge the patient. Once you remove the ICU, after 6 hours, if the patient is okay, you can send the patient home. Right? So, you need to know how to remove the ICU. So, make sure that the patient is quite alright. Once you have taken the ICU home, clinically good, observe for 6 hours, and if everything is okay, discharge the patient. Any questions?